Welcome to the guests, and thanks very much for your contributions. I particularly want to welcome the previous statement from Professor Toomey on the nature of the type of care we provide for our older persons, and one thing is for certain, we're all going to be there someday, and so this is really important that we do get the future right. But just want to take a moment to look back on the past and look back at what your report set out to do, because I would like you to comment that I think your terms of reference were quite restricted in terms of what you could delve down into what happened in the nursing homes, that you were tasked to provide assurance that national protective measures were in place in line with international guidelines and to provide recommendations. But you don't seem to be able to move beyond that to say who was actually responsible for or what was actually responsible for the spike in the deaths, the 56% of all deaths in our nursing homes. I know you do identify some areas, but you yourself, Professor Toomey, have said repeatedly that you completely disagreed with the policy decisions that were made over the last decades, and that there was a huge gap in support for the care of our elderly, with 8% being in private settings where there was no oversight. And I would like you to comment on the terms of reference. Would you have liked to see them expanded so that you could make clearer and more concise recommendations about the nature of care going forward? Because I think it's well known that what they call the grey rush is now an investment opportunity for a huge amount of global corporations, and that it's exploitative of the care of our elderly, but rather we need to see new ways of developing that. And I, for one, will be really pushing that we need to look at reversing the private-public trend that has developed over the last 20 years, from 80% private to 20% public and voluntary, and reverse it the other way around. And the second question I'd like to ask you, and maybe you could answer in some detail, there's alarming reports or worrying reports, and there's no doubt this was going to happen again, that the numbers of COVID cases are beginning to rise again in our nursing home sector. And you've made really good recommendations on stuff like access to rapid testing with fast-track results, ensuring that all residents coming from the community or transferred from hospitals are tested. I think you probably have in there that all staff should be tested. And I wonder, would you comment on, are you confident that that is actually happening now, that the testing of staff, that the provision of PPEs, that the protection of our elderly in these homes, with all of the recommendations that you're making, are actually happening now? And I guess you probably may not be able to answer that in detail, and you've already given Deputy Shortall some answers about the near future, but I'm concerned about the now and the return of COVID to our nursing homes in numbers.
Thank you, Deputy. I think, first of all, I think we can give some reassurance. There is already a programme of ongoing testing underway of staff in all nursing homes. 2 such exercises have taken place already, one in June and the other over a 4-week period ending in August, in which all staff in all nursing homes were tested. And the good news in a way is that not surprisingly, thankfully too, is that the pickup rate in terms of positivity was very low, 0.1 to 0.2%. So I'm confident that that process is in place. I'm equally confident, and we are equally confident, that there is a significant and real commitment to ensure that every nursing home has a core supply of PPE, and will, in the event of a surge, be able to access without delay more PPE. Let's not forget, the PPE dilemma wasn't confined to the nursing homes. It was equally a difficulty in the acute hospital sector, and we all remember the airplane arriving in from China with equipment that wasn't suitable for either facility. So I'm confident on that score. On the issue, am I confident that the model will change? In my view, it has to change. The 80 years plus age group is going to treble in the next 30 years. And quite frankly, if in 30 years' time we have a model of care for older people that is 3 times the current one, we'll have failed abysmally. Denmark, for example, haven't built a new nursing home since the late 1990s. Finland, which has a population a bit like our own, although it's a much more scattered country, has 7,000 plus residential care beds for older people. We have almost 32,000 beds. So what is it that Finland is doing that doesn't require everyone to be institutionalized? So that's back to my earlier point of having alternative models. And let's be clear now as well, to be fair, there's a huge number, there is a huge number of older people being looked after currently in their own homes with the support and help of their families. And that is something to be commended, and very often under difficult circumstances for the carers. And that's where the majority of them are. But there are other models of care that will lighten the load on carers, such as the smaller congregated settings I mentioned. My nature is one of optimism. You might say utterly misplaced, but that's the way it is. I have been involved with reports for many years in the health area, and some of them, many of them, and I heard the chairman's comments earlier, his pessimistic comments about reports generally. I understand that. But there is really an urgency, and I think maybe one of the fortunate, in quotes, spin-offs of COVID is that it has been a good mind concentrator. And maybe it will be the case that cross-departmental support, cross-sectoral support will achieve the change that I absolutely believe must take place.
Just to come back at you there.
The points around the terms of reference, because I think it's very important. We were given those terms of reference to assure that the preparedness would be in place and what the international evidence was. And we did do a very wide stakeholder consultation with every agency that has a responsibility in this area, and also with the general public, with the nursing homes, with themselves, and with those relatives and families who had been exposed to this. So I think we were very focused on what lessons were to be learnt and what preparedness was needed in the work that we were doing. And we have learned a great deal more. I, like you, and we would all share the hope that if we are again going through another resurgence of this virus, that we would be prepared in terms of understanding what the condition is, understanding who the vulnerable patients are in relation to it, understanding who the vulnerable residents are, having the adequate PPE and other infection prevention control pieces in place. And I think that key things like having in-house capacity to take swabs, having rapid testing, having the HSE respond in relation to that, we are keeping a firm advocacy position on making sure that that's being done.
Can I ask two final shorter questions? One is, have you any concerns? I know you've clearly outlined that there needs to be testing, and you believe it's happening, of residents being taken out of being patients in hospitals into nursing homes, and that testing will happen and will be done. Have you any concerns that should any patients in the nursing home sector become very ill, that they will be moved to the hospital setting where the acute care is needed? And secondly, I'd just like to ask you to comment on the fact that even though you're very optimistic about changing the model for the future, as we speak, planning permission for large-scale models of nursing homes across the country is being sought, is being granted in many, many cases to big corporations who are building the sort of capacity you spoke about earlier on into the hundreds and 200s size bed units, which aren't appropriate, and how we're going to change that. There's also just the question of bodies who are concerned with the care of the elderly, like Age Action, like SAGE, who don't believe that the report deals with the questions and answers that the families and that some of the staff have around what happened in the nursing home. So would you agree with me that although your terms of reference didn't require you to look at those things, that there is another body of work required to deal with the concerns of the families about what happened to their loved ones in all cases?
Okay, thank you, Deputy. I'll take the question regarding the families. I agree with that something does need to be set up to investigate or to talk through the care of relatives in residents in nursing homes with families. There is a huge gap there at the moment. SAGE Advocacy provided a lot of support through the the first wave when nursing homes were closed and when families were having difficulty in visiting at end of life, which was very, very traumatic when end of life visiting wasn't allowed. So in the meantime, nursing homes are the providers, and they do have a responsibility to actually meet with families, to provide the information that they hold and to release it if requested under FOI. But I strongly support that the advocacy of Sage Advocacy is a really good organisation who's got a lot of experience, and their service should be promoted both by HICWA, the Department of Health at the moment. The Minister, when he's meeting with families, it may be worth saying that it might be a good idea if he suggests to families they bring an advocate with them as well. And the advocates really do make sure that the residents and their families, their voices are heard and that they understand what's being said. It is very important. It's a huge gap at the moment, and I feel very, very strongly about that. But it will have long lasting effects if we don't deal with it now. It'll come back 3 years, 5 years, 10 years down the road for those people.
On the issue of were we concerned about somebody being very ill in a nursing home, being able or unable to get to an acute hospital, I think the answer is that one of the pluses of the COVID response teams that we are now recommending be permanently institutionalised under recommendation 7.1 as community support teams. One of the advantages that were reported to us by the participants, which included community nurses, geriatricians, infectious control staff, public health and so on. One of the things to emerge from it was that heretofore the amount of support that nursing homes got, particularly in the private sector, perhaps more than the public, though in both, was a bit haphazard. But by these committees coming in, they were able to give support, in this instance clinical support where necessary, which sometimes allowed the medical issue that had arisen to be dealt with there in the nursing home satisfactorily. Or indeed, it equally could have said, look, this person actually needs to be transferred to an acute hospital because of their issue, and they would transfer it to a hospital. We're saying that from now on, that community support team needs to be a permanent entity, and it will, I think, lead to much better clinical decision-making about patients, residents, who should be transferred when, and indeed sometimes the other position, which is somebody who is very close to the end of life and dying, which nursing homes are a bit frightened about the publicity that might accrue to them if the person does die, or if there's more than 1 or 2 die in a week and whatever. If there is support given, no, this person actually is dying, and the humane thing to do in this instance is to support that person where they are and where they've been looked after so well for so long, and that's the appropriate answer to be given to them. And if there's a structure in place like the community support team to support that kind of decision making, it will be a much more enhanced level and standard of care, as well as a reassurance to both families and residents and to the staff in residential care settings.
Thanks very much.